Hi everyone, welcome to this showcase today. I'm thrilled to be able to present to you the Haematology Optimisation project and also the digital morphology pilot. Before we do that, I'd just like to acknowledge the traditional custodians and all the land that we're working on today and pay our respects to ancestors and elders past, present and emerging. And thanks for joining us today. I'm really thrilled to have you with us. I also just want to let you know that we are recording this session today, and so that will go online for anybody who wasn't able to join to be able to have a look at that. So I'm just going to start off and give a little bit of a background of the Haematology Optimisation project. So just to remind everybody where we came from, so the haematology program of work started after the haematology tender. It was a huge analyzer rollout. It really included the haematology analyzers, middleware, morphology reporting, digital morphology pilot, and the coagulation analyzers. But obviously today we are just talking about the second phase, which is the haematology optimization. And just to remind everybody that this actually happened in the middle of COVID. And it really ended up not being just an analyzer transformation replacement, but a transformation project. Yeah, so we also just to remind everybody that pre the go live, we had a variety of analyzers right across the state, and different rules, different middleware, and different SOPs. So at the end of phase one, look, things weren't optimal. The dictionaries we had realised had been configured differently. The workflows had been optimised across the state, but I guess what we realised is that, you know, with the familiarity with the DXH analyzers, and once everybody had familiarity with that, it was worthwhile going back and then having a look at the rules and the workflow. Some of the operational areas also had different SOPs, and so there was also a thought that there was a need for gap training and professional development. And I guess in a nutshell, we felt that the staff were working harder and not smarter. And so that's really why we wanted to start the haematology optimization phase 2. What we also found is that the film review rates had gone up instead of down. So another great reason to go back and optimize the workflows and processes. So this is, I guess, just a little bit of a timeline. I won't go into it in detail, but just to say, this is where I came on at the beginning of 2019, and Ruth Yum Sung did a fantastic job during the implementation. And then with phase 2, obviously realising the need for us to go back and do an optimization phase. So I'm going to hand over to Karen now, and she's just going to go through the haematology optimization project and the deliverables. And over to you, Karen. We'll hold questions till the end of this session, and we'll have questions at the end of each of the sessions. So over to you, Karen.
Hi, everyone. Thanks for joining. So first of all, the first objective we had was to optimise the workflow from specimen reception to the validation of full blood counts to morphology, to maximise the ease of the sample handling, operational resources, and limit manual steps and processes. So the deliverables were that we compiled SOPs and we standardised all of that across the state. There were a lot of issues from the rollout with the DXHs. So we did a lot of work collaborating with the different operational areas, getting a lot of feedback, and created sort of a register of people's questions and issues that they were having. And we sort of collaborated and grouped them into similar situations. And then we continued meeting with Beckman Coulter over several months, where we presented them with these questions, and they got back to us with solutions or non-solutions. We also established a discussion group with ANZ and DXH, a Remesol group, which comprises of representatives of people. All of them are using DXHs, some are using Ramosol and some aren't, from New Zealand and Melbourne and the ACT, and that will continue on. We also reviewed and harmonised the Ramosol dictionaries, which Vanessa spoke about before. So originally they'd all been configured differently with different styles and rules. I think all the IT departments, had their training with Ramosol, and then they went back and implemented in the best way that they could. And so now the rule structures are all configured the same. They're all named the same way in all the different operational areas, and they're updated to be consistent across the dictionaries. We also developed new rules to streamline the workflow at the client, and this then enhanced the functionality of Ramosol, including DIFPAD. And we still have some rules awaiting approval from the clinical stream. So the outcome was largely complete, and now everything has been transferred back to the IT operations and clinical streams. So the objective number 2 was to achieve an intervention rate of about 12% at the Ramosol clients. So that's on the bench level when the full blood counts are processed through the analyzers. So we designed a new workflow. We had meetings with each lab before the implementation to explain the workflow and the changes and to seek input and feedback. We discussed and staged with IT and operations, so everything was very scheduled, so things could be switched on at the right time. And then the project team travelled out to every site on the days that the go live occurred. So we were there to iron out any problems and make sure that the workflow continued to move smoothly. The outcome of this was a lot of the staff saw it as an opt-in rather than all-in. So we sort of received mixed feedback from some of the sites, and I think it sort of depended on the size and the workflow and the volume within the laboratories, which made a bit of a difference. Some sites found a big reduction in manual handling, and some sites decided to continue with the current manual workflow. So objective 3 was to increase efficiencies and reduce turnaround time for full blood counts and morphology, where morphology was performed on sites. As defined by the clinical stream morphology group, the turnaround targets 1 hour for critical requests, 4 hours for urgent requests, and a maximum of 16 hours for routine requests. So the deliverables, we were unable to obtain the maximum turnaround time. We were unable to obtain urgent turnaround times. And it's just noted that the urgent turnaround time relates to the urgency from the LIS, not actually from the rules triggered in Ramosol. So it's not really accurate. And the morphology turnaround time was impacted by staffing of morphology in laboratories, and therefore it's not really a good measure of the project success. The outcome is that the turnaround times are being monitored, or were being monitored by the project team, and the turnaround time data will continue to be provided to managers and clinical directors each month. Objective number 4 was to increase knowledge and support for staff performing haematological testing. So with this, we delivered on-site education of staff, and we developed education training modules and delivered those through the Haematology Education series, and these were recorded on Teams. We're currently developing a haematology SharePoint site that everyone will have access to, where all the SOPs and documents will be in one place, along with all the educational material and recordings that we've done with the DXHs. And objective number 5 was to achieve an average film review rate of 17 to 18% across the state. So where New South Wales Health Pathology started, which was pre-phase back in October 2018, the average film review rate was almost at 25%, which was a long way from the target of 17 to 18%. And at that point, only 13 out of the 61 labs had a film review rate of less than or equal to the proposed target of 17%. The overall film review rates from 2019-20, which was pre-go live, to post-optimisation project, which was July, August this year, we've seen a significant decrease from 22. It did increase a little bit, as Vanessa spoke about before, when the DXH analyzers were rolled out, but after the intervention from the optimisation project, there was a significant decrease in the film review rates overall. And this is just another diagram. So you can see the red line was the average, which is a film review rate in 2018 of nearly 25%. And then the average down at 2023 at the end of the project, which is excluding RPA, Canterbury and Omni. 41 labs now have an average film review rate of less than or equal to 17%, and 46 labs are less than or equal to 18%. So overall, the impact of the Haematology Optimisation project on the film review rates was a positive improvement, as you can see there. Some sites received quite significant. Concord is quite a notable one there. And not many sites were worse off after the implementation of the project.
Thanks, Karen. Really appreciate you doing that. So I'm just going to carry on and show the film review rates from overall, not just the optimisation, but also from pre-DXH. So just so we can have a look at that. So this is what we've seen, a pretty good improvement right across the state. So North had quite low film review rate already. Omni I'll explain about in a minute, but we can see a good improvement really right across the state. So this is just looking at the different LASs. As I said, AusLab had quite low film review rates already, and the stats are a little bit dirty. The stats from AusLab, they do include films that are not reviewed, whereas Omni include all films made. And so that's why you can see, I think the Omni rates are a little bit higher, but I think overall, great outcome. Rural and regional, their film review rate is 17.6. I thought I'd just call that out as a separate one. So let's have a quick look at the big 7 labs. So I've just had a look at these, separately. Randwick, we can see that the film review rates are quite high, but when we think about the complexity of their patients, they have a high paediatric and neonatal population. And if we think of other sites, that's probably reasonable. And like I said, it includes all the films, not those, rather than those just reviewed. We can see some great insights there for Liverpool. John Hunter's very low. John Hunter, though, just to say, they don't do adult haematology, and that's why I've included the MARTA as a comparison. The difference between the MARTA before pre-go live and now is that they used to do films twice a week on haematology patients, and now they do look at all of them. And but we can see some really good drops there and improvements across a lot of the labs. I just wanted to call out as well, so Concord was a really interesting example. Pre-go live, their film review rate was 26%. Post-go live, when they went on to the XQ interface, it went up to 35%, which was, pretty hectic for them. And then when they went onto the Remisol interface, it actually dropped down 22%, and then post-optimization 20%. So quite an interesting case study there. One other thing to note in the data is that the film review rates are higher when the turnaround times are extended, and we can see that in some of the data across when we've been monitoring it. So the benefits, what are the benefits realised? So what we saw with the optimization project is if we overall we found a savings of almost 170,000 slides that wouldn't have to have been reviewed. So what does that equate to? At 100 slides a day, it equates to almost 8 FTE, and at 80 slides a day, if we've got it's a bit slower, it's almost 10 FTE. So some great savings in terms of staff time across the state. Project came in on budget, even though we did extend the senior hospital scientist by 3 months. And moving forward, there are obviously benefits realised back to you back in operational areas. So hopefully now you are working a bit smarter rather than harder. That was always our intention, that life would be easier for people in the lab. Some additional benefits that we wanted to just call out. So certainly there's been a reduction of manual handling for some labs. I think there has been improved knowledge. There's always more that we can do. One thing though that I think has been really great is the interaction across the haematology lab. So relationships built, networking, supporting for troubleshooting, etc. I think, a lot of the documents have been harmonised, and I think that will hold us in good stead now for future rollouts and for Fusion moving forward. I think a strong foundation has been built, and also we've established some great relationships interstate and Australasian as well. So next steps, we have now handed over the project to the Haematology Technical Group, which is part of the clinical stream. And so they are taking that forward with rule changes and discussion on, more, I guess, optimization of some of the SOPs, particularly platelets, the platelet workflow. And so I think Tim's continuing with that at the moment. Like Karen said, we are just finalising the SharePoint site, so that'll come out to you hopefully by the end of the year or early next year. We probably do need to look at training and competency documents. That's one thing that we still didn't quite get to, and additional training for staff. That has been a request that's come back from some of the staff in the labs as well. I'm sure that there's still more films that can be reduced, and but that'll be for the clinical stream and the haematology technical group now to take on. But just a few thoughts from me, I guess, before we finish up. And one thing that I observed in the labs, why is haematology still so manual when we compare it to some of the other departments? And middleware really, it's a software to review and validate results by exclusion instead of handling 100% of samples. When we handle 100% of samples, there's actually risk that goes with that as well when, staff are handling all the samples rather than just looking at those ones that are critical. Quite a number of our other labs, they use tracks and sorters, for example, pathfinders or, chemistry on the track. So I think that's something for us to move into in the future to help reduce our manual handling. And even slide writers and label printers, for example, some of our areas in the organisation still don't even have label printers. And just, I guess, a question, for us moving forward and our challenge to us as an organisation, our projects are always iterative and there's always more that we can do to improve. So New South Wales, when we think about how our film review rate is now, which is fantastic, and I'm just so thrilled to be able to present that to you today, and hopefully you're seeing that improvement in the labs. Compared to where we were in 2018, we have improved a lot, but there are other labs around the country, around the world that run large big tertiary labs which also have lower film review rates to us, and some are using the same type of analyzers. So I'll just finish off on a patient case. I think it's always great to finish it back to a patient. So this was a 16-year-old woman, 1 week postpartum. She presented to ED with vomiting and diarrhea and an altered mental state. Many hours later, the haematologist was phoned and a diagnosis of TTP was made. The patient died before she could receive the correct treatment, and she may have died anyway. It was a complex situation. But what I really wanted to call out was this was actually her result off the analyzer. And from me looking at that result, the results, the histograms, the scatter plots and the flagging, it's really clear that this was a TTP. So one of the take-home messages for me is there's more we can always do to train our staff, train, and always make sure. The other second, I guess, takeaway is to make sure that we do resource our programs suitably. So I just want to acknowledge lots of people have taken part in this project. There are a lot of people online, haematologists, scientists, and staff in the labs that have contributed to this program of work, and the Haematology Optimisation project as well as the project team. Our Remicel experts ended up being called our Remicel whisperers, but there's been a lot of people right across the state, and Karen as well, Priya, Abigail, others that have contributed. So thank you very much. And I will open it up to questions now before we move on to the next one. Yes, David, thank you.
Someone's always got to go first.
Absolutely.
I did hear mention Fusion. So all this work is feeding into Fusion and then subsequently Epic, I'm presuming.
Absolutely.
Then, granted, we don't know a lot about Epic so far. Do you think we're going to see further improvements when we're all on the same system?
Look, hard to say, but I think wouldn't be surprised if we do. One of the challenges that we found on the project was that we have 4 different LISs, so that was really difficult for rollout. We were doing 4, rollouts effectively instead of 1 rollout. And also how the LISs interact with middleware is all very different. So that made it difficult to, get standardization versus harmonization. And look, I'm sure that as we go on, there will always be improvement, and having 1 LIS will be hugely easier than having 4, definitely.
No doubt. Okay, thanks.
Any other questions? Okay, so thank you once again. If you do have any other questions, by all means, something you think about later, or your staff, please email. Very happy to follow up anything at a later stage. I'm now going to hand over to Mandy Hubbard. We're now going to go through the digital morphology project. So first of all, the pilot, and then that will be followed by Susanna, who did the proficiency and drafted up the training framework. So Mandy, I'll hand over to you.
Thank you, Vanessa. Okay, I'll just start sharing. Okay, take if we can all see that.
Yep, that's there.
Yes, coming through. Great.
Yep.
Okay, so good afternoon, everyone, and thank you for the opportunity to talk about this. My name is Mandy Hubbard. I'm the Senior Hospital Scientist at the Coffs Harbour Laboratory. Today, I'll be presenting to you the New South Wales Health Pathology pilot studies. I'll start by giving an overview of CelloVision, outline the pilot project that we've done, the uses and benefits of CelloVision, and then I'll end with some case studies. So just for those people that aren't aware of the different analyzers that are available, there's 3 analyzers on the market produced by CelloVision. We have the DM9600, which is this analyzer, the large analyzer, and this analyzer is located at our John Hunter laboratory. It has a capacity to scan 30 slides per hour. And it has a conveyor belt where you can load 8 cartridges, and each cartridge holds 12 slides. So in theory, you could load 96 slides and walk away and let the analyzer do its thing. And then we have the DM1200, which is located at our Coffs Harbour laboratory. This analyzer has the capacity to scan 20 slides per hour. It has a chute where we load 1 cartridge at a time, so 12 slides in 1 hit. And then we have the smaller analyzer, the DC1, which is located in our chemistry laboratory. It has capacity to scan 10 slides per hour. So it's more suited for the smaller laboratories. So what is CelloVision? And CellaVision is an automated digital morphology analyzer designed for in vitro diagnostic use. Though for our pilot project, we use it primarily as a screening tool. It has software that locates, pre-classifies, presents, and stores digital images of a specified number of white cells and red cells and platelets from a Rite-Schemza or Rite-Schemza-like blood film. So with the classification and the characterization, that information has to be entered into the analyzer. So we've done that for our analyzers, and that was based on the reporting guidelines of New South Wales Health Pathology, which are underpinned by the ICSH guidelines. So how does CellaVision do its thing? This cartoon that you see is what is inside the larger analyzers. So that's the DM96 and the 1200. So what it does is, give me a sec, on screen's gone here. So what it does is we have two objective. We have a 10 times objective and 100 times objective. The 10 times objective is what's used to identify the monolayer. And the monolayer is the area where the analyzer will do all of its characterization and pre-classification. And then we have what we can create is a 50 times magnification, and that's done by having a relay tube that sits over the 100 times objective and cuts it down by 50%. So the 50 times magnification is what's used to do the pre-characterization of the red cell morphology. The 100 times lens is what we use to do the pre-classification of nucleated cells, and these are classified into 18 classes, from your normal white cells to your immature white cells as well. I should mention as well that for the red cell pre-characterization, the larger analyzers have what we call the advanced red cell software, and this allows the analyzer to characterize red cells into 20 different characteristics, inclusive of size, color, and any inclusion bodies, like your hydrogel bodies, your papillae, or your parasites as well, which I'll kind of talk about a bit further. So in general, what happens is we have our slides, which we have a barcode for. And I should mention that the barcode needs to be chemical resistant. We get the slides that are then stained either on SMS if you have the larger analyzers, or using a aerospray for the smaller sites. The slides are inserted into a magazine. The magazine is then inserted into the analyzer, and the analyzer automatically starts analyzing those slides. The slides then are reviewed with the software from the DHX. So it does have a neural software to review those slides. Okay, so just to give you an overview of the pilot, so this is now, seems like a while ago. Before we could actually start with our pilot, we had to kind of set up all the hardware. So that was, acquiring the scanners at the various sites, ensuring that they're the appropriate monitors, because you need a certain pixelation to be able to review accurately your characteristics and classification of cells. As mentioned, the larger analyzers have the slide stainer maker, and we use the aerospray manual staining for the smallest analyzers. We had to then have a staining protocol, which had to be standardized, make sure that we had the zebra printers as well as labels as well, and make sure that they were interfaced to be creating those labels. Make sure the ports are set up so that we could access the server software. So I should mention that we have a server software which is basically sits with GovDC, so that and it's independent of the various LISs. So it means anyone that has been given access to the software server can actually access and review those films, which I think is great for remote review. And I'll show you the importance of that in the case later. So then we had to, organize our SOPs, perform the major verification, which was done at John Hunter, and then again look at our statewide reporting criteria, and then make sure we had all our training competency documents done, as well as our proficiency QAP. All this kind of had to happen before we could get our accreditation with NATA, which we got earlier this year. We're very, very excited about. As Vanessa mentioned, we do have the HealthShare site, which all these documents are stored for people to be able to review. We have a memorandum of understanding with South Australia Pathology, and South Australia Pathology has been using CellaVision for quite a few years now. So we did go and visit them and see how they were using it, and it was reassuring for us to see that even with them who weren't interfaced with their systems, they found that there was a huge improvement in their turnaround times of films and uptake of staff with the new technology. Okay, so these are just some, results from the major verification, and this is looking at the white cells, and you can see from not only the slopes and the intercepts, but also from the correlation values that all the white cells except for our basophils, which I think is more indicative of basophils, low numbers rather than the system itself, all of them correlated really well. And they was concerned about whether or not how blasts would be picked up with CellaVision, but I think those figures, I think hopefully will alleviate any concerns that people might have. So uses and benefits. What we decided, based again with the consultation, what we're doing in South Australia is where we normally would do a white cell differential based on 100 cells, white cells. We've set CellaVision to do a white cell differential based on 250 cells. So you can see here, basically, this is a screenshot and shows us the total number of cells that have been counted. This is the differential. The green boxes indicates the classification, the pre-classification by the analyzer. If the morphologist decided to reclassify any of these cells, these boxes would turn blue. And this here is the patient data. And so once we are interface, the information from the middleware will populate in here. So you'll have the patient details, any flags that are associated with that film, as well as the patient results as well. And each, the way the system works is that each cell type, so your white cells, your red cells, and your platelets are reviewed separately. So, and each tab will have a section where you can actually document the comments for that particular cell type as well. The other thing I should mention, which we found quite useful as well, is that for those patients that have a really low white cell count, below 1, you can run make a couple of slides for that patient and put that same episode number through the scanner a few times. It means that you're getting a more accurate white cell differential. CellaVision will then just merge those results and give you a more cumulative report from that. Okay. We also have a reference library. So that means that, particularly for the younger or newer morphologists, I should say, if they're reviewing any particular white cell, they can actually look up in the library to see what a normal one of that, so what that kind of cell looks like, I should say, whether it be a normal or abnormal white cell. The library will have a variety of images that they can actually compare their image that they want to look at against the library image as well. So I think that's quite useful. It also has capacity to magnify a particular cell that maybe you're having a challenge identifying, so you can try and zoom in and classify that cell as well. So we also have the ability to send slides off to the hematologist for review. So what happens is ultimately the morphologist, and I should mention this is quite important, the morphologist has the final say in terms of the classification of the blood film, so whether the red cells are white cells in the platelets. The analyzer will suggest a white cell class, and then the morphologist has to either agree or disagree with what the analyzer says. Once they've basically done all the review of the red cells and the white cells and the platelets, they can sign that slide off. If they feel that that slide needs to be referred to a hematologist, they can select on their in that particular episode number, they can select this icon here, which then appears on with that particular episode number. It means then that the hematologist can sort the worksheet and have a look at the slides that are only for them to review. So we can basically, the selection criteria here, or the search criteria, can be just changed to viewed and marked for pathology review, and only the ones for the hematologist will populate. They can also then basically set that they view only the ones that are for their site. So they can choose Coffs Harbour, John Hunter or Kempsey in this area as well, and only for that hospital will appear. But it also means that if they want, for example, they were at a location where the site didn't have a hematologist, they can call another site and say, can you ask the hematologist to have a look at the site, give the location lab number, and then they can enter the lab number here, and that particular episode number will pop up, and the hematologist can then review that. And that then leads me to our first case, and this to me just highlighted the importance of this instrument. So the first case is a 20-year-old female who presented with ED with query sepsis and anemia. You can see the indices here. These are from the GHX, white cell count of 46.7, hemoglobin 26, platelets of 20. The flags from the GHX are in the Imbrands, your left chest, and your blasts. The chemistry, the chemistry, you can see that the main thing really is your LDH is elevated and your D-dimer is also slightly elevated as well. What's good to look at is the timeline for this patient and how things were expedited for them. So the sample was collected at 10:30 at Kempsey ED, and then basically entered into the list at 10:59. At 11:05, run on the DHX. At 11:24, the morphologist has a look at the blood film, and then at midday, the patient is admitted into hospital. At 12:26, another differential is performed and blasts are identified. You can see all your blasts in there. And then at 12:29, the hematologist and the ED doctor are notified, and this film is uploaded to Celavision. So initiated by the lab senior, which was a fantastic idea, they opened up discussion using Teams and showed the Celavision images to the hematologists from both Port Macquarie and Prince of Wales, and the preliminary suspected diagnosis was identified. The patient was then discharged and transferred to Port Mac and then Prince of Wales. But if you have a look really like the timeline, in a space of less than 9 hours, it's gone from patient basically presents to ED, blood being collected and having preliminary diagnosis. And this, if you look back, this could have taken some time between taking photos, if you had a cooloscope to send images, or sending the manual slide down to where the hematologist might be located. So I think this just was a great case of how Celavision really improved patient care for this patient. So another just a snapshot again, just showing you ultimately what happened with the patient. So the flow was into John Hunter, bone marrow was done at Prince of Wales, and the cytogenetics as well. So the patient was confirmed as having AML. The second case that we can have a look at is a malaria patient. So it's a 48-year-old female that presented to ED with fever and lower back pain. They had an onset of fever for 3 days, which seemed to settle with paracetamol, but was reoccurring when they presented. No vomiting or diarrhea, no headaches, but there was a loss of appetite. Now, as mentioned when I talked about some of the capabilities of Celavision, is that when you have a look at the characterization of the red cells, it does have, particularly the bigger analyzers that have the advanced red cell feature, it does have the capacity to actually pick up your parasites as an inclusion body in the red cells. And so this patient full blood count was run through, the platelet count was low, and this were the images that we got from television. And it did pick up with these greetocytes. It kind of picked them up as a nucleated cell. So it was in the tab with the white cell tabs, but the infected red cells were shown up as parasite inclusion bodies in the red cell tab. The patient was then ultimately diagnosed with plasmodium ovale via DNA PCR. Another malaria case as well we have is a 37-year-old male returning from PNG 13 days ago, now a new onset of fever and sweats and body aches. Again, we see the platelet count over here of 45. And as I mentioned before, in terms of the different characterizations we can have with red cell features, these inclusion bodies, the parasites are down here. So we can see that it's detected some parasites with this patient. And then, when we've done a density count for that patient, we found that, they've had a density count of 27.2 times 10 to the 9, and they were diagnosed with falciparum as well. The next last case that I wanted to talk about was a patient that had gestational thrombocytopenia. I should have mentioned, early on as well, that with the platelets, if you are concerned about the platelet count, you can do a manual count using television. So this is what happened with this patient. The patient had presented with a platelet count of 74 with an induction of labor. But the anaesthetist was concerned about administering the epidural with the platelet count this low. When this film was reviewed, it was noted that the patient had some giant platelets and some large platelets. They then performed a manual platelet count, and the platelet count came out at 100. And then, the following week done and was 93 postpartum. But yeah, I just think it highlighted the care that the patient could give and kind of confidence could give the anaesthetist to be able to administer the epidural. So what next for us? So we've got bigger, who we're hoping to get accredited, not accredited, hopefully by the end of this year or maybe early next year. We're working on interfacing the middleware with Cellovision and the Feathered Edge software. Now, I got yesterday, and I've been trying to get some information about the Feathered Edge. So I know there's been a lot of concern about Cellovision's inability to have a look at the Feathered Edge. So software has been released on the Feathered Edge for Cellovision. It's a free software upgrade that we will be getting early next year. But this basically is what we'll be able to do. So you'll be able to select the area that you want the Feathered Edge to happen, and then you can navigate basically using these buttons down here, and then tag a particular area of interest that you want to have a look at. So I'm sure that a lot of our morphologists who have had concerns about not being able to view the Feathered Edge for your platelet clumping or your larger abnormal cells, this hopefully will make them feel a bit more comfortable about using television. And I'd just like to acknowledge just a few, and this is just some of the names of the people that have been involved with both the pilot, but also just the staff at the various sites that have kind of taken this new technology on board and helped, embed it in our day-to-day work. Thank you, everyone. And does anyone have any questions?
So I can see you've got a question.
Thanks, Vanessa. Hi, Mandy. Very good presentation, quite informative.
Thank you.
A couple of questions pops up in mind. What is the data for storing one slide?
So is that you want to put my volume up?
How much data you need to store one slide? 1 GB, 2 GB, 3 GB?
So sorry. Go ahead. Finish.
Yeah, and how we are planning to store, because I think NPEG guideline is 1 year or 2 year to store the slide image or glass slide. So is it in cloud? Is it on a local server? How are we going to, first of all, the data size, and then what is the plan to store this huge amount of data, and then how to retrieve them?
Okay, I'll start off, and Vanessa, you can correct me. We do have a DC server, which is a government server where all this is stored. My understanding that it's there, we can archive it, but it's there indefinitely. Vanessa, am I correct?
Oh, sorry, I should put myself off mute. So we have servers set up on GovDC path, and so we have adequate amount of storage now. We obviously with glass slides don't need to keep it forever, but we do have enough storage, and we can increase that storage with eHealth if we need. Going back to your first question about the size, the file size, it actually depends on the analyzer. So the DC1 scan is much higher than the DM 1200 and 9600. I can't remember exactly off the top of my head what it is, but we can get that to you.
All right, excellent. And last question, sorry. How you see machine learning and artificial intelligence playing a role in this, with all these data sets we are collecting internally around the cells types and different kind of leukemias and all that? Is there a plan to introduce machine learning around this?
Sorry, go ahead.
You go.
Yeah. I was going to say, in terms of machine learning, I think Celavision doesn't use that. I think their feeling is that we don't want to influence how the machine learns, and so that if people are putting in the wrong information, then the analyzer learns the wrong information as well. So they just do upgrades with any new information that they get. But there is no, it's not machine learned, no.
All right, thank you.
I do think that there is opportunity for us in the future to use AI between information that comes off the analyzer, the results, and digital, and include, you know, for example, results from other disciplines, as well as you know, patient information out of the EMR. So I think there's a world of opportunity for us there in the future. But yeah, lots of things we can do. Kevin?
Hi, Vanessa. Hi, Mandy. Thanks for presenting this presentation from IT. I just want to ask about, with the pilot site, have we interfaced any sites with Remisol? If they are, have you got any issues, or how do we resolve those issues? And also the second question is, what's the expectation of interfacing the Celavision with Remisol, and what we are doing with what are we going to do with DivPat? I believe this will create some sort of I guess bridge between, you know, how do you work around the workflow utilizing Celavision, and also is Celavision able to receive previous results from Remisol?
So my understanding is that it can't receive previous results from Remisol. You'd have to review those previous results, cumulative results from Remisol. Interfacing is back on the agenda. The guys in IT are working on that. I think we're looking at next year, and I think some UAT testing is hopefully happening this year, before the end of the year, and then further testing will happen next year. In terms of the other question, sorry. So you wondered about UAT testing and review, and I think once the interfacing side of it happens, I think the hope is that maybe we can lose DivPad and just basically have Remisol and OzLab and Celavision as the main platforms.
Okay.
One thing to say, which we probably glossed over a little bit, and I didn't point it out, is that the 3 scanners are actually all connected up. So that's all connected up through server software and GovDC. So Mandy can see John Hunter work. John Hunter can see Kempsey work, for example. So they can all see the slides. There's different ways that we can operate that, whether it's side by side or first in, first out. So there are different, you know, opportunities for us in the future there as well. But sort of waiting for the interfacing to drop at this stage. Leslie. We can't hear you. If you might be on mute, are you?
Yeah, yes, thank you for that.
There we are.
Firstly, thank you for the presentation. It's really interesting. Couple of questions. Firstly, with the escalation to the haematology registrar or haematologist, can information be provided on the reason for the referral by the scientist? Quite often we get slides and we get no information and we're not sure what particular problem the scientist is having with the slide because it may not be obvious. One. Number two, if the registrar can't manage it, can it then be further escalated from them to the haematologist? And then I've got a question about that gestational thrombocytopenia you had, and you said you did a manual count. Was that an actual manual on a glass slide, or was it an estimation of the digital image? And if that's the case, has that been validated?
Sure. Okay. I'll start with your gestational question. Yes, it was on television. Yes, we have validated the platelet counts on television. Basically doing manual counts on a film, also then comparing that to television. So we had to basically calculate, each analyzer has to have a platelet estimator factor that is entered into the analyzer, and that's based basically on counting manual platelet numbers, comparing that to what you're counting on television.
All right. Do you want to get to my other questions? Thanks.
Yes, sorry. And then the other question, I'm losing track. And so your other question was about...
it was about escalation. Could we get information on why the film is being referred?
Yeah, so when the morphologist refers a slide, a pop-up box comes up and they have to document why they are referring that slide. And then when the hematologist opens up their slide with that icon, it pops up with saying, slide referred by Leslie or by Mandy because of blah, blah, blah. And then they can basically review that slide. I think in terms of the second part, if the registrar wanted to escalate it, if they didn't sign the slide off, that will still remain on the review list. But if they signed it off, it would go off the list. So they'd have to basically not sign it off for the hematologist to then have a look at it.
How would the hematologist know they wanted it to be reviewed? Because there might be quite a lot of slides on that list, and we could just assume that the registrar hasn't got to them yet.
I suppose you'd have to have communication with the registrar. I know some sites have a workflow where they have there is no. I don't think there's a capacity on the analyzer to say reg review now for hematologist review. Not that I know of. I'm not sure if anyone else, Vanessa or Susan, you can highlight that. But I don't think that's a capacity.
I think Leslie, I think it's a workflow that we need to work out. So in the analyzer, there's only one level of escalation. So for example, that could be to a hematologist, a registrar, or a senior hospital scientist first, but then you can't escalate after that. Ideally, it'd be great if you could. So I think we just need to work out a workflow of escalation and how we communicate that. We haven't quite got to that yet. I guess being in the early stages, but really happy to have your input into that.
Happy to contribute. Yeah.
Great, thanks.
So the other thing is, I don't know if you'd populated it, Mandy, or whether this was something that was just dragged across by the software, but does Celavision provide information on the other biochemistry and other results, or did you populate that space next to your slide? It doesn't.
Yeah,
that would be so handy.
That would be wonderful.
Yeah.
No, unfortunately, no, it hasn't got the capacity to that stage.
Right.
It would be very useful.
It doesn't, what I've seen though, Leslie, at another lab is they've set up a macro to run in the background. So they actually have two monitors open. Maybe they were split or not, I can't quite remember. But what the macro did was it automatically opened up the results in the LIS or between the software. So somehow, I think there are some clever IT things that we could do to support that, but we'll have to talk to clever IT people.
Okay, well, it would be highly desirable, at least at the registrar level, and potentially at least one of the senior scientists in the laboratory.
Absolutely. Couldn't agree more. Gina.
Hi, guys. Hi, Mandy. That was a good talk. Yeah, thank you. Just a couple of things. I just wanted to ask, in your experience, like how many erroneous results have you come across? Like, for example, have you gotten like water artifact and it's come up as malaria, like something like that? And also, how often have you had to refer to the microscope?
Yeah, I should highlight as well that, you know, this is all based on the quality of the slide and the quality of the stain. If, you know, you have to make sure you've got a good quality slide. Sometimes if you do have, you know, particular red cells, that's where we seem to see a lot of the challenges is the red cells are sitting on top of each other. It might say that maybe it's saying there's pathognomonic bodies or some sort of inclusion body. So with those cells, you have to be you might have to reclassify them. And we did notice that, yes, that's definitely something that was there. But that tended to be based on the quality of the slide. You know, the better the quality slide, less likely you have to reclassify. And then in terms of, you know, having to, the percentage of slides that we had to review, again, I don't think we've actually captured that data as yet. It'd be useful to kind of know from know the sites that have been using it. We haven't really stored that information, but yeah, that would be useful.
Okay, thanks.
One other thing to add, Gina, that you've just reminded me of, we had Karen Collins, who lives and works down in Griffith, do remote reporting for Coffs Harbour because they were down on staff. Karen, I don't know if you were there and you want to comment on that, or Mandy, you've got a comment, either of you?
Yeah, I know sorry, go ahead, Karen.
Oh, sorry. Yeah, no, I found it good. And the more you do, the faster I got. Obviously it would be better if it was interface. So, you know, you sort of had to have a few things open. I looked at, over a few months, I looked at, you know, probably a couple of hours a day of slides for Coffs Harbour. And I think there was only one time where I really wanted to refer to the microscope, and it was a MDS. And there was, like quite an assortment of white cells in there, which I sort of would have been more comfortable with the glass slide. But as Mandy said, it's really is dependent on the quality of the stain and the quality of the film that's made. That's really crucial because it affects the monolayer and then it affects everything that you see. But when you're reviewing it in Cell-O-Vision, it is quite obvious that they're not Pappenheimer bodies, that they're not parasites. You know, it's if the slide's not made properly and it's quite scratchy, it will categorize things as schistocytes. But when you're actually looking at the film, or the images, you can actually see that. So you wouldn't misdiagnose, I don't think, from it. But I guess the key will be getting that confidence and training people that, you know, of the quality that's required to be scanned in Cell-O-Vision.
Yeah, and I know for us in Coffs, it was really useful having, you know, Karen being able to help. And that's another great feature is that, you know, if you've got a log on for the server, you can actually log on from anywhere and have a look at those slides. So it means that sites that have a backlog or, you know, are down on morphologists, you know, we can kind of step in and help out those sites as well. And I think that's going to be something quite useful.
Wonderful. Leslie, we might take you as the last questions before we move on.
Thank you, Vanessa. Look, sorry, I mentioned this earlier. Look, one of the problems we have is a lot of calls occur after hours and on the weekends, and it would be really lovely to have access to this for a quick diagnosis in these urgent cases like the one you showed, Vanessa, offline for our haematologists. Is that going to be available?
I hope so. I can log in from home on my laptop at the moment, so I can't see any reason why others can't.
But you've got a special laptop that's got all the right connections, Vanessa, and most of my clinical guys are not going to have that.
Okay, well, that's something we'll have to think through then. We really just have to be on the health domain. But again, probably something for us to work through with the IT team. So thanks for raising it.
Needs to be on the mobile phone. It needs to be on the mobile phone if it can. Otherwise,
okay.
I'm going to have scientists taking shots of it on their mobile phones and sending it to me, and that's probably undesirable in terms of record keeping and so on.
One
could
thing we
use-
could do, sorry, Mandy.
I was going to say, we could use like what they did with that case in Kempsey, use Teams, you know, everyone's got Teams on their phone, and just, you know, make a meeting with that particular registrar or hematologist, and then just basically show them the slides via Teams.
Yep.
And the images are
that's
quite
the
clear,
solution.
Leslie, as well. You know, like I've reviewed it on my laptop.
Yeah,
and, you know, and the quality is good on there as well.
Yeah, but Teams is probably a good solution. I agree.
Yeah.
We'll find a way. Wonderful. Thanks so much, Mandy. I really appreciate that your presentation. So we might move over to Susanna now, and she'll take us through the proficiency program.
Hi, everyone. Lucky last. Let me just share my screen. Can you see that?
Yep.
Yes.
Perfect. So I was involved in the proficiency side of this digital morphology pilot project, and we had a number of successes this year. So basically, with our staff reviewing either remote review or reviewing the television slides, we had to make sure that they were competent in doing that. So you needed to compare apples with apples. So we set up this proficiency survey program. It was given out monthly, and we had regular participation in the from the pilot sites. We also produced interactive webinars where they could come on at the conclusion of the surveys, and it was sort of like a debrief and a feedback session for any participants. We put together a good working group as part of the consultative process to actually formulate the framework of the proficiency program. I've also produced some digital morphology educational tutorials, which is also available through the Haematology Educational series, and that's become part of the digital morphology training module framework as well. So the program itself, it's a proficiency software program developed by Celavision. And what we do there is basically the aim is to assess and monitor and promote staff competency using this digital platform. It's a very standardised approach. So as examiners, and there was a panel of us, we formulated the test, created the test. The individual participant basically got an email notification saying that a test was ready for them. They would log on individually to this Celavision proficiency software program and see which test was ongoing, which test they already had completed as well. They could view their test there, their results. They could compare it to their cohort or to their examiners. So we created the test. They got on, performed the test, submitted it, and then could view the results automatically if we chose, or there were end dates where then that the results would go out at a specific date. So we used case studies from our New South Wales Health Pathology Databank. So they were our patients, but they were all obviously de-identified. And as I said, the participants got that feedback at the conclusion and the submission of their tests. A little bit different to the reporting side of Celavision. When you opened up your test, you basically had to do one thing first, and that was to classify your white cells. They came across as unidentified, and in this one there were 110. So we're sort of undenied about whether it should be 250 or 100. Basically, towards the end of this year, there was a consensus through the working group that it would be at 100 for the white cells. So they would literally move these individual cells across, or they could group them. There were very many different ways to put them into their proper differential groups. And as you can see on the left-hand side, it shows which ones they could put it into. Now, unfortunately, the first one says band forms. And so when we get on later in this presentation, I'll show you that quite a number of participants put their neutrophils automatically into the band form instead of the segmented neutrophil file. Secondly, they would then also do a morphology comment in their pop-up box and put in their morphology comment according to our New South Wales reporting criteria. And this just shows that there was different ways of putting those cells into the different subpopulations. They could leave us a little note or we could leave them a little note per cell if there was a cell in question as well. Then they would also grade the red cells. So once again, in the reporting version, you would have, for the larger two analyzers, you would have what we call the advanced red cell characterization, and it would do it for you. But obviously for competency, it's all about our participants knowing what cells are what and putting them into the correct poicular site. And they could grade them mild, moderate, and marked by moving that icon over to 1, 2, or 3. Once they did the white cells, red cells, and their morphology comment, they would sign off the slide, and then it would automatically appear in their account as a completed test. So the framework itself, with consultation with the working group, we put it together. Firstly, we had 100 licenses to work with. That's what Celavision gave us. So every morphologist received a license to be able to participate in this proficiency program. The program itself, or the project itself, we basically said it should be monthly surveys, 2 slides per survey, with a small workflow quiz to show us their thinking of what they would do with that particular slide or that particular case. The KPIs for the surveys were, firstly, just to get participation. That was number 1 in the first phase. And of those that participated, they would have to have completed 70% of the slides that were given to them, or the surveys that were given to them. The level of agreement for red cells and white cells were defined by the comparison with the examiner. And by the examiner, that was basically a panel of 2 senior scientists, including myself and Karen Collins, and our clinical lead haematologist being Dr. Tim Brighton. The clinically critical morphology that was captured was captured either in the morphology count of the survey itself, or to an add-on little workflow quiz which had a link per survey. And failure to identify those clinically critical morphology components, that participant would then require retraining. And some of those clinically critical morphologies are listed here below. So I'll just give you a couple of examples first of what it would typically look like. So we did, I sort of put an info sheet out, basically telling them how to answer the survey as far as what to be included as artifact, such as smudge cells and, debris. So they were very specific instructions on how to attempt this survey. And then came the clinical part, which was the actual case study. So in this particular one, it was, they'd receive clinical notes of a male, of a 78-year-old male with incidental finding. Then they had the full blood count given to them. And then they also received a scatter plot with basically the full blood count, again, the actual flags that popped up for that case study, the scatter plots and the histograms. What I wanted to do, or what we wanted to do as a panel, was not only just get them to do agreement or disagreement on the actual cells, but to interpret it as more of a whole picture. So they also got biochem results, micro results if they needed to get those, coag results. So really it was more not about an RCPA type of answering, but more about how they would do it in their normal daily life as a morphologist, because all of these things were available to them to actually formulate what was going on with that patient. So in this particular instance, there was an example. This example was of an ALL. So the comment would have been, that blasts were present. We counted about 52% in this case. That there were some occasional nuke reds. Nuke reds aren't captured in the red cell characterization, so we expected them to at least, in their morphology comment, and that it would be reviewed to a haematologist, again, according to our reporting criteria. So how did they go with that one? This is what a typical result summary would look like. You get your slides on the left-hand side. And then you get your agreement and disagreement with your white cells on the right-hand side, from the middle of 0% going out to 100%. And then on the left-hand side would be your red cell agreement, again, 0% to 100%. The least agreeable is on top and the most agreeable at the bottom. In the middle here, with it also shows you in a different aspect the same results as this as the chart. So from this one, there were 10 participants that actually completed the test. 22 did not attempt it. And of that, the lowest agreement was 17%, the highest 98, 93 for reds, and 100% for the at the other end. What we do have here, all these little boxes, are our feedback to our participants on the results. So where did they lose their marks, I suppose, that 16.9%? Well, basically, again, they were putting it into subpopulations that were available to them, even though we explicitly said, please do it by our reporting guideline. I feel like there was, again, the confidence and this all being new to them, they thought, well, it's there, let's use it. So quite a number of people were putting their neutrophils, if they were band forms, into the band form population. And then also the smudge and the artifact, we asked them to put anything other than if it's related to a CLL as artifact, but unfortunately some put it as smudge. So it wasn't as though they didn't, that they were not competent, it was just the way they used this particular program. Another aspect was that some participants didn't actually class all the cells and so lost their marks. This particular individual thought that those abnormal lymphocytes were more like lymphoma cells as opposed to blasts, and they were very similar in some aspect, and so chose to put them under the abnormal lymphocyte, which is a malignant lymphocyte population as well. So that's where they were getting those lower marks and more disagreement with the examiners. Another way you could do it is actually looking at the individual cells, which is amazing compared to sitting at a double header and saying, oh, at 9 o'clock and, few cells to the right or left, look at this cell. They could actually identify which cells were misclassified by the participant. So on the right-hand side, we have the examiner's results for all lymphocytes. On the left-hand side was this particular participant who then classed, some of these as blasts, where we called it lymphocyte, or we called a particular one here as blast, this guy here, which would be equivalent here, and they could put it into their lymphocyte count. So you could always see how they were losing or gaining, like where the agreement and disagreement was happening, either per participant or you could do it per cell class. Now, this one, again, there was variability in putting out the morphology into the subgroups of, say, the variant lymphocyte forms. So they called them either reactive lymphs or variant lymphs or large granular lymphs instead of putting it all into the lymphocyte count. So what you're seeing here, the yellow is the participant. The blue is the participant, the yellow is the disagreement between examiner, and the grey is what the examiner counted. So if you put that yellow one on top, that particular participant would have got 100% on segmented neutrophils. So that's where the discrepancies were occurring. Another way is looking at cell classes. So all the participants for, say, the neutrophils and for the band forms. So there's so many ways of viewing how participants have gone in this survey. At the end of every survey, I put out a test conclusion, which was a PDF attached to each survey. And so it sort of closed the educational loop on this survey, what the patient actually had, how it was reported by our registrars on our peripheral blood, on the flow that was done, the bone marrow aspirate, as well as obviously the FISH and the cytogenetics, which gave it its ultimate classification of lymphoblastic leukemia / lymphoma with a BCR-ABL fusion gene. So they would get each one at the end of each survey. So just another example, this one was in the August survey where, again, 84-year-old male, no clinical notes provided. Well, that's not unusual at all. We got the full blood count, HB of 66, low red cells, hematocrit, and very low platelets with an MPV that was quite high, which to me says, there's a range of platelet sizing. and you could see that in your histogram here as well as just having that suspected flag of a red cell platelet overlap. So again, wanting the participant to use all this information to conclude what they thought might be the diagnosis. And as you can see in this one, on the left-hand side, the agreement with the examiners was really quite good. This particular participant on the right-hand side with the white cells had put all their segmented neutrophils in the band form, unfortunately. So it wasn't as though they hadn't known what the cells were, but that's why you've got such a low one there. Again, we gave them a feedback on what the slides were down there. Out of this, 18 people had completed it, 15 people had not. I think I was being quite ambitious on putting some of these scientists onto the program. We found that, there were delays in getting them trained, and also from a myriad of reasons, confidence levels on, for them to actually participate. So perhaps the participation rate is a bit skewed that way. As far as the red cell characterization, this is all about how far they were discrepant to what the examiners thought were on this film for red cells. So in this particular case, we thought as examiners there were 3 marked schistocytes. There was discussion whether to call it moderate or marked. You can see that the cohort, the majority thought it was more moderate. Everyone picked up that there were schistocytes, which is great, but because they had included other poikilocytes, that sort of detracted from the agreement percentage that was given out for each participant. So again, they got a test conclusion. So I put out there, what a MAHA was, what indices you would see, what poikilocytes you would see, the ICSH definition of a schistocyte, which included quite a myriad of different poikilocytes down there as part of what they classify as a schistocyte, and how we would report it in our organisation, what we would call mild, marked, and mild, moderate, and marked. They also got, I thought was very important, some of the very common conditions that are associated with MAHA as well. So that came as a test conclusion, and again, closing that educational loop for them. So once they were all in, the examiners could extract this information from this program, and they can pull out the results summary, the white cell and the red cell classifications. Comes out as a CSV, which we sort of converted to Excel spreadsheet, and given it out to their seniors and their managers. So how did these participants do? Well, we had 10 proficiencies done this year. Again, I said the participation rate itself might be a bit skewed because I was being a bit ambitious about how many people could actually sit for these assessments. But the agreement and disagreement of the whites and reds was really good, as expected, because they're all very competent morphologists, albeit using a digital platform. There were variations, as I said, and that was not classifying using incorrect categories, whether that was intentional or unintentional, as well as being just unfamiliar, getting the confidence with this sort of very new platform. The conditions that we sort of gave them were basically from a normal blood film. It usually was one red cell condition, one white cell condition, right through to your chronics, your hemolytics, the acute leukemias. And as you can see, on average, done very, very well for the agreement for white cells and for red cells. Again, see that 4% has brought down that average. Had they put it into the segmented newts, that would have been 100%. So well done to our morphologists. We also did that workflow quiz. So again, we wanted to work out what would they do with this film. So there were 5 questions posed to them. And it was just a Teams, sort of a Microsoft Forms or quiz that was put in as a link. So in the last 6 months, these were the surveys that were given to them. And as far as suspected diagnosis, and as I would expect, the morphologists did really, really well. mostly 100% on that. If the lower ones were due to really more like one or two not putting in the nitty-gritty diagnosis, but putting in sort of a differential diagnosis, and it was a very small cohort, so that sort of pulled down your percentage rate there. But all in all, 100% there. The other one, that why would you refer it? Again, that was question 4. Pretty much 100% on that, bar a couple. And that's a critical one. You know, is it because it's a MAHA or an APML? So we expected our morphologists to do really well there. The variations that came were here. Was you know, is it an urgent one where you have to actually chase a haematologist or a registrar? Got some variables on that. And secondly, would I refer it to a haematology registrar? Mostly done well. There was one that I thought was quite sort of questionable in regards to a sickle cell. Some people didn't think it needed to go to a registrar. So this is where I think we can improve, and that would be really by having more of a using our standardized interpretations and comments and following our haematology reporting criteria, which is already there. We've already got that in place. Some things will be tweaked as we speak, including the haematology registrar referral list, but having more of that standardized approach would actually allow us to see how our morphologists are doing and how they are actually reporting. So again, the variability in this particular program that we've established was the staff numbers actually performing the surveys, taking their time to get onto those surveys and having the confidence to do it. Also the variability on how they reported and graded, and also capturing that data. So we've decided that making it more standardized and using a BI dashboard would help. Having codes in there would help, so that they would have to use those codes in order to answer, and then you would see how they're doing individually. And having that statewide morphology reporting criteria really embedded in the operations. One of the challenges was, again, the platelets. That isn't addressed in this proficiency program. The other thing that I was working on were the training modules for competency as well. So we, using, again, the working group, we've sort of, and are still involved in doing this, we're looking at the training modules. So each training module includes identification of cell type and training by condition, such as all of these that I've listed here, and haven't really sort of expanded on some of them, but you get the gist of what is being covered in the training modules. Now, we have it that, you know, we would use recognised prior learning first, and then also having the morphologists go through the online completion of the morphology modules online, looking at the television recorded sessions that we had produced. Also have scheduling that these modules themselves would have an interactive webinar at the end of each module, at the end of each of these, and using the competency case studies on the proficiency program, and training our staff to report in a very standardised way using our reporting criteria and referral guidelines. So could this be a model for competency and training in the future? There's lots of pros, I believe, for using it as a competency tool. Firstly, you know, it is in the cloud server, so there's a little sort of, you know, what was I going to say, interference with our own computer systems. There's just having that consistent standardized competency where you can actually see how they are answering and what knowledge they have, having it as a standardized approach. You can see, you know, as I said, apples to with apples. With the training modules themselves as well, being able to access them remotely, not having to leave your lab to go for training, it would really address the limited numbers of morphology trainers that we have in our organisation, and having that sort of no discrepancy or variability when you're reviewing these modules. just having greater flexibility and mobility of moving around the organisation, knowing that you are competent, which with it, whatever form, you could actually go from site to site or remote review. So I think, it could be a way forward, but obviously more discussions are to be had. Any questions?
Thanks, Susanna. Any questions from anyone? Leslie.
Getting in quick. Thank you very much, Susanna. I've got a question. Can you actually produce a one-off assessment, competency assessment, for instance, put together 10 or 20 slides and get somebody to do them at one sitting? We might have, new scientists starting in our laboratory that we're not familiar with, or I might want to run it as a once-off for the registrars, for instance. I mean, can you do that, or are we looking at an ongoing sort of competency?
Oh, right. Well, I suppose it will come down to, again, that recognition of prior learning as to whether they could sit as a one-off. I would view this more as an ongoing competency assessment, regular competency assessment. Just
I mean, I can see that's the way it's set up, and obviously we'd use it like that, but it would be nice to have that flexibility in being able to, put together a slide set rather than having to deal with live slides.
I think then they would have to have the familiarity of what these images are, like looking down a glass slide is slightly different to the images. So they would have to be comfortable and signed off for being able to use television images.
Yeah, that's right.
And then, what do you think, Vanessa?
I think the software's got a lot of flexibility, Leslie. So I think there are different ways that we could use it. We could use it as a 20 slide set, and you just give, because you have a library of lots and lots of different slides. So you could choose 20 slides that you'd want to give them. And, it could be 20 leukemias one time, it could be red cells another time. So there's lots of different ways that you could use it.
Great.
Yeah.
Yeah, because when we might have somebody who needs some special focus on leukemia, for instance. They may not see it very often, and it would be great to be able to put together that sort of slide set.
I think so. And it could be neonatals or pediatrics as well, or malarias, or, so I think there's lots of opportunity for us to, use it for that in different ways, definitely. And for different levels as well, for registrars or, no. And I think what we've sort of thought that could be possible is with the training framework, train by module, and you have a selection of slides that you could provide at the end of each module, but then you could have an overall competency at the end of it, or we could just use the ongoing competency once they're trained. So I think there's some of the things for us to nut out and how we could use it, but it's given us a good foundation and a good basis to get an idea of what's possible, I think.
With our education program that we've got running, we are actually doing some modular training, and Susanna's done it already as well. And there's the potential to link education with on-the-bench training with a competency down the road as well, just to maximise the interactivity between the various ways we're delivering training in morphology. Anyway, just something to think about.
Yeah, great idea. Great idea. Any other questions? So, there we go, Lawrence.
All great stuff. Thank you, Susanna, Mary, and Vanessa. Just a question. When do we think that this might be rolled out or implemented across the state?
Good question. So that's what I was going to follow up with next. So I think the digital morphology pilot, we're still waiting for the interfacing for it. Like we said, we've built a really great foundation with what, Susanna and the team have done with the proficiency, and we've got a draft for a training. I think the next steps are establishing some consultation around the state. So today was, I guess, a bit of a showcase. But while the project team is very familiar with it, I think there's probably a need for us to do more consultation across the state. And we've, mapped it in 1 or 2 operational areas. So I think, again, the next step will be to socialise that, see and get input from other operational areas around the state. In terms of digital morphology overall, I think that's a conversation that we need to have as an organisation. So the idea was set the pilot up, get some familiarity, and then work out as an organisation where we go to from here. So that'll be the next conversations in terms of what we do with that. So hold on to your hats. Let's see where we get to with that next year, but some more conversations to have. And Lawrence again.
Sorry, last question.
Sure.
I don't know if you've looked at it, but you may have. Can you tell me the labour saving that you may have in time that you may have discovered when using Celavision and etc., removing Remesol and the reduced amount of diffs, just from the morphology point of view? When you're using Celavision and everybody's sort of proficient, do you see a saving in time for labour, or have you seen it?
So I think we're in our infancy in using it. 2 of my learnings from this whole digital morphology pilot implementation, etc. One is it takes time for the staff to adjust. So I think we're in our infancy to see the full opportunity with that. And the other thing, my biggest learning is that, labs need to have capacity to implement it because it's quite a different way of doing morphology. I think what we're seeing, so we haven't done any numbers on that, but what we are seeing initially is that it does save time, and the publications will say that as well. In terms of exactly how much, we're not sure, but we do think it's quicker than microscopy. Leslie?
Thank you.
Sorry, I think you're on mute.
Sorry, just a follow-on question from Lawrence, and you probably haven't done it, but maybe it's something we could look at when we do look at it, is the saving in training time and competency time as well, because that's a huge rate limiting step in the laboratory and a resource issue, and that would be, I'm pretty sure this would save that sort of time.
Yes, agreed. And I think there are different ways that we can do that, and how we do it is what we need to look at as well. I think what it does is it also gives us the opportunity for cohort training, so we could train several people all at once, which I think would be hugely beneficial. Yeah. And we're sort of trying to move it to saving time of the trainer. So what we're looking at or drafting up is, some online, some self-learning, some one-on-one online, some cohort training. So I think there will definitely be savings in there, definitely. We'll have to look at it. So we're on time. So thank you so much. A huge acknowledgement and thank you to all the project teams, both scientific, IT, haematologist, clinical streams. We've had lots and lots and lots of people right across the state that have provided input into both of these projects, and I'm hugely grateful to the enormous amount of work by everybody, and particularly those that have been on the project. So thank you. Thanks for joining us today. It's been really great to share this work with you. Please reach out if you've got more questions or want to know more. Thanks, and enjoy your day.
Thanks,
Thank
everyone.
you.
Thank
Thank you.
Thank you.
Bye now.
Bye.
Thank you.